Facebook and YouTube. So there is so many people, and if there is any question from the YouTube or Facebook, they can send it, and the management even they will send to us, and we are ready to answer this. Also, I'd like to announce for the conference, MEOM, third MEOM conference that will be on 23 to 25 of September 2021. And we are having a very huge number of eminent speakers worldwide. We are about more than 165 speakers in 3 days. They are going to cover most of the subspecialty of ophthalmology in a good way, and mainly in a case-based discussions that can be also very innovations and very informative for all our attendees and even the speakers. So today I'm also, as usual, we are having many eminent speakers, and most of them they are well known to you, but I'm also happy to just to introduce them. Before that, okay, can you go down, John? So our speakers today, the first speaker, Dr. Yahya Salah, is a professor of ophthalmology, Cairo University, Egypt, consultant, cataract, cornea refractive, eye care center, Cairo, Egypt. Dr. Yahya, well known of ophthalmologist in our area, Middle East and worldwide. Second speaker, he is the first time to have Dr. Indra Prasad, and he is my dear friend, and we met before a long time ago, maybe not long time, 5 years. Unfortunately, we didn't meet, but it is our pleasure and honor to be with us today. Dr. Indra Prasad is a alumni of RBC, AIMS, New Delhi, presently Director, Senior Consultant, RBI Institute, Research and Training Center, New Delhi. He has been engaged in continuous research and innovation for the last 35 years, having publication of original work in national and international. Welcome, Dr. Indra Prasad, for us, and it's our pleasure. Our next speaker, also my dear friend, and he is now well known with us, everybody know him, Dr. Safwan Al-Bayati, FRCS. He's a consultant ophthalmologist, medical director of New Vision Eye Care Center. He's a well-known cataract refractive and cornea, and also vitreoretinal surgeon. Also, my dear friend, Dr. Osama Jlaidi, is a consultant ophthalmologist, Moorfield Eye Hospital, Dubai, cornea, cataract, and refractive surgeon. Also, finally, and last and not the least, my dear friend, also Dr. Hassan Khalid. He is an MD, APO Ophthalmology, GBO Ophthalmology, FRCS. He's a consultant ophthalmologist, chief of cataract and glaucoma unit in Maghrabi Eye Center, Makkah, Saudi Arabia. So most welcome all my dear friends. Before we go to our meetings, we are having also our friend Dr. Mina Ashraf from Bausch & and he will give a presentation about a new product, and it will be very informative and new things that we need to know about it. Ashraf, the mic with you.
Good evening, everybody. Thank you very much, Dr. Mohammed, for arranging this meeting, and it's a pleasure to be with you all today among this amazing group of speakers. Today, we will briefly introduce to you Rekugel. Rekugel is a re-epithelializing gel for the management of post-operative discomfort and superficial corneal abrasions. Rekugel is a three-dimensional gel matrix. It's composed of dexpanthenol, carbomer polymer, and water. Its composition is 5% dexpanthenol in addition to 0.2% carbomer, with a viscosity, pH, and osmolarity that are very well tolerated. The viscosity is medium, the pH is similar to the natural tear film, and it's a hypoosmolar medication, so it can also help in wetting the corneal surface. Rekugel, as I mentioned, is a corneal re-epithelializing agent composed of the bioadhesive cross-linked polymer, which is carbomer, which has an optimal viscosity characteristics, high water retention capacity, and also it has an excellent bioadhesive criteria which helps it to stay longer on the ocular surface. In addition to dexpanthenol, which is a provitamin B5 that permits corneal epithelial migration and multistratification. Also, it prevents scar formation on corneal stroma. If we look at each of those two components separately, we look first at the carbomer. Carbomer is a cross-linked molecular chain that has three important characteristics that helps it in re-epithelializing the corneal surface and also in wetting the corneal surface. First of all, it has a thixotropic colloidal, it's a thixotropic colloidal system. So with the frictional forces during blinking and also with the tear film soles, it partially breaks down the polymer structure. So the viscosity decreases during installation and blinking. So it's a gel only inside the tube. Once it is dispensed or distilled on the ocular surface, it loses this viscous criteria of the gels, and it becomes a viscous liquid that has an adaptive viscosity versus linking. Second criteria is the deposition effect, which helps in the continuous fluid secretion. So it helps in producing a slow release of both the dexpanthenol 5% in addition to the water. Also, it has an excellent bioadhesive property, which increases the wettability of the corneal surface and helps Rekugel to stay longer on the ocular surface. So the base is carbomer. The active ingredient is dexpanthenol. Dexpanthenol is a provitamin B5, which is an essential component also of the coenzyme A. It's an essential cofactor for intracellular energy production, and it helps with the turnover of membranes and structural protein components. Dexpanthenol helps to stimulate the proliferation and migration of the epithelial cells. It helps with the multi-stratification of the corneal epithelial cells and prevents scar formation. There are three major effects of Rekugel gel in this context. First, it helps with cleaning the wound. Second, it helps with surfacing the wound by helping the migration process. And also it helps in the reformation of the multi-layer epithelium. So it helps in the epithelial growth, both in the horizontal dimension and in the vertical dimension. So it helps both in surfacing and multi-stratification of the corneal epithelial cells. So when to use Rekugel? Rekugel can be used in cases of corneal epithelial defects and also in cases of corneal erosions where we need to help in promoting the re-epithelialization process in both indications. Rekugel is used for re-epithelialization in many indications. For example, post-surgical, post-refractive or post-cataract surgery, after foreign body removals, for thermal or chemical burns, and mechanical traumas, and also can be used as an adjunctive therapy in keratoconjunctivitis sicca and in ocular infections. Rekugel has clinical trials in three indications. First, it's used as a first aid. Second, in post-cataract surgery. And third, in post-refractive surgery. First, Rekugel as a first aid. This study was done in a hospital university in Spain. They studied both the efficacy of Rekugel in terms of re-epithelialization and the tolerability in terms of adverse events assessment. The inclusion criteria for this study was patients with corneal erosions caused by foreign bodies deeper than 2 millimeters in depth, and the removal of the corneal foreign body was done by a 25 gauge needle and epithelial scrapping. The efficacy results after foreign body removal with Rekugel. First, we had 50 patients included in the study. 27 of them came back for the control visit. Out of those 27 patients, 23 out of 27 had complete re-epithelialization in 48 hours, and 27 out of 27 had complete re-epithelialization in 96 hours. So we had complete re-epithelialization in 85% of the patients after 2 days and 100% after 4 days of treatment. And these are some pictures of the efficacy results pre and post using Rekugel. Also, the subjective healing outcomes were excellent. 100% of the patients reported subjective improvement in red eye, 92.6 reported subjective improvement in burning and itching, and also 88.9 reported subjective improvement in blurred vision. So the efficacy results and the tolerability of Rekugel as a first aid after foreign body removal, we had 85% of the patients with complete reepithelialization after 48 hours and 100% in 96 hours. Also, it is very well tolerated. 3 patients only reported blurred vision during installation, and 2 patients reported itching. Second indication is Rekugel following surgery. We had this study for 80 patients operated for cataract or retinal surgeries. They were both randomized to receive either the conventional topical treatment alone or conventional topical treatment in addition to dexpanthenol 5%, 2 drops 4 times daily. This study showed that dexpanthenol 5% effectively decreases the healing time of corneal and conjunctival wounds compared to conventional therapy alone. And we can see here the results with Rekugel or with the standard therapy alone without Rekugel. So as we can see here, adding Rekugel to the standard therapy, like the orange bars, we can see that post-operative at day 2, day 3, 4, and 5, Rekugel was very effective in reducing the subjective symptoms and to speed up the process of wound healing and corneal reepithelialization. Also, the subjective symptoms included here eye pain, injection, burning, and photophobia in patients undergoing cataract or retinal surgeries. And those results or the difference reached statistical significance at day 2. So the resolution of conjunctival congestion and edema and the improvement in the healing was observed on day 2 of Rekugel treatment. Third study for Rekugel in post-cataract surgery, we looked here at the ocular discomfort pre and post-operative cataract surgery. Also here we have the group on the left side of the slide. Those are the patients who received the anti-inflammatory treatment, the conventional treatment without Rekugel. And on the right side of the slide, we can see the patients who received the conventional treatment in addition to dexpanthenol. And as we can see here, that there was a 65% reduction in the symptoms of ocular discomfort when we used Rekugel in addition to the conventional treatment. Finally, Rekugel in post-refractive surgery. This study measured the efficacy of the dexpanthenol-based gel in reepithelialization following refractive surgery, and we compared here the days needed to achieve complete reepithelialization, comparing dexpanthenol 5% to acetylcysteine 5%, and as we can see here, that complete reepithelialization was achieved in 2.7 days with dexpanthenol compared to 4 days with acetylcysteine. So in conclusion, Rekugel contains dexpanthenol 5%, suspended in carbomer-based gel. Carbomer helps in wetting the corneal surface to improve or to facilitate the reepithelialization of dexpanthenol. It helps with bioadhesion to stay longer on the ocular surface. So it gives a very good chance for dexpanthenol to work effectively. Dexpanthenol effectively facilitates the healing of the corneal and conjunctival damage. Clinical efficacy of dexpanthenol 5%, 2 drops 5 times daily is evaluated for efficacy to heal the corneal and conjunctival epithelial damage after surgical operations. And as we have seen, that the results were obvious at day 2 of treatment in terms of decreasing the conjunctival congestion and edema, smooth healing of the wound, and decrease in the subjective symptoms. Rekugel is indicated for the treatment of post-operative corneal and conjunctival lesions as a supportive treatment in addition to the standard treatment protocols for cases of cataract, refractive surgeries, and ocular traumas. Also, it can help in discomfort derived by scatterization or wound healing of the corneal surface epithelium. corneal erosions and reduce tear film stability. Also, it helps with regeneration and lubrication for contact lens users and dry eye symptoms. It can also help in reepithelialization for heat or chemical burns in addition to ocular traumas. Rekugel can be used like in the studies for reepithelialization. We use 1 to 2 drops 4 times daily, but it can be used whenever necessary. So when the need arises, it can be used. There is no limitation on the frequency of installation. It's provided in a multi-dose gel package that contains 10 grams of Rekugel. Thank you very much. And if you have any questions, I'm very happy to address.
Thank you very much, Dr. Ashraf. It's an excellent presentation about Rekugel. I think there is many questions in my mind. Also, if there is any question before that from any colleagues, Dr. Osama, Dr. Hassan, Dr. Safwan.
Yes, I have one comment.
Yes, please. Yes,
I'm using Rekugel, Mina. Great, thanks for your presentation. You clarified a lot of points for me. Actually, I'm using the Rekugel post-refractive, and we are running two control. One, I'm using contact lens with diclofenac sodium. I'm sucking the contact lens and the diclofenac sodium, waiting for it to dry, and then suck it in diclofenac sodium and using it, especially in trans-PRK, transepithelial PRK. And now I start another line to use Rekugel with it. And I found that the discomfort that I have no pain in the first 3 days post-op, but I have discomfort. Now, the pain that we are facing at post-PRK in the first 3 days, we had obliterated totally. Maybe the third day when the dose of the diclofenac sodium reduced, it started. But when we start Rekugel, the third day, that discomfort, the patient have it, they stop complaining. And when I'm asking them, really, they don't have any discomfort starting from the first day. And that's the only issues that I found it in a post-refractive. Now, in healing, till now, I didn't use it actually, but I was very happy to use it post-refractive.
Okay. Any other comments or questions to Dr. Amina? Dr. Hassan, you are mute. You are mute. Can you unmute yourself? Sorry.
Yes. Yes. Also, I have a very good experience with Rekugel, especially in patients with corneal abrasion, as it enhances the epithelialization of the cornea. Also, I always write this Rekugel in patient after Ahmed valve implantation to decrease the foreign body sensation from the nodes of the sutures. Thank you, Dr. Mina, for this nice presentation.
Yeah.
Any other question, Dr. Yahya, Dr. Osama, Dr. Prasad?
Well, unfortunately, we don't have it in Egypt, so I have no experience in it. As it looks nice. Is it going to be in Egypt, Dr. Ahmed? Dr. Mina?
Mina.
As far as I know, it's not in process, but I'm in charge of the Gulf and Middle East region, like Gulf and Levant. It is now available already in the GCC countries and the Levant area, but I'm not aware if it is planned to be launched in Egypt soon. Unfortunately, I don't have an answer. I'm sorry.
No.
Dr. Prasad, you have any experience using these molecules in India?
It's a nice presentation, and this product is still not available here in India. But we have the local product called it's a D-panthenol. It's produced by the Agenta Pharmaceuticals. We have been using that, and really it's effective. But its only thing is like it's in a gel form, and some of the patients they complain because when you put the gel, the blurring of vision for some time. That is one problem, and sticky lids is another problem. So I don't know because Rekugel has the similar kind of problem or not. I don't know.
No,
so I
no.
don't have experience with Rekugel.
Okay.
Mina can answer this question. Like
yeah. Can you comment, Dr. Mina?
Yes, actually, Rekugel is based in a carbomer gel form, and carbomer has what we call dixotropic characteristics, the dixotropic characteristics makes it gel only inside the tube. But once it is distilled on the ocular surface, the gel is broken down into a viscoadaptive medication. So, you know, with pressure that happens with blinking, it loses its viscosity. But once the patients open their eye again, it spreads again on the ocular surface and restores its viscosity. So it has this type of adaptive viscosity, and it's a viscous liquid inside the eye. It's not a gel anymore. I'm not aware of the medication available in India, in which platform it's based, like the dexpanthenol is dependent on which base. But for Rekugel, it has this carbomer base that helps to reduce any intolerance caused by the gel formulation.
D-panthenol is it's basically an alcohol based, because is Rekugel also an alcohol based product?
No, it's carbomer. Based. Yes, and the carbomer, it has an effect that is similar to the mucin layer in the ocular surface, so it helps a lot with the bioadhesion. So it has a bit of close characteristics to the natural tear film once it is instilled on the ocular surface. So it doesn't have this gel intolerance that we can see with traditional gel formulations.
Yes.
Thank you.
Oh, sorry.
Thank you, Dr. Mina. There is one question, Mina. Is there any role for Rekugel in treating, not treating, I mean in the facilitating or enhancement of the treatment of corneal ulcer? I mean, after the corneal ulcer is healed from the infections, is there any role for that?
Well, for corneal ulcers, we do not have any clinical trials that tested the effect of Rekugel on corneal ulcers. So the answer is no available data on ulcers. However, for ulcers, the corneal abrasion, it's not only a superficial abrasion, it's a bit deeper. So what Rekugel can do is only to help in the epithelial regeneration, which is the outermost thin layer of the ocular surface. It cannot help with deeper erosions. So it can only help the outermost layer. Beyond the epithelium, it will not have any effect. So I don't know if this would help for corneal ulcers or not. Theoretically, it can help a little bit with the superficial surface, but it cannot heal the ulcer because it doesn't work deeper than the epithelium, and no available data on corneal ulcers.
Okay, Osama, if you have any comment about this one, if you have any experience using.
Yeah, for corneal ulcer, once there's no infection, it promote the healing regardless, in lubricant to promote. I think it will help with epithelium healing when the infection is controlled, you know?
Yes.
I think sometimes we are using, you know, any gel or lubricating or gel to, for example, facilitate the healing and prevent the dryness. If that one, it's affect in the corneal abrasion, it's, theoretically, as Dr. Mina, it can also help in the end stages of the corneal ulcer. Maybe, I don't know, but we are most of the time using lubricating drops. So this one is one that also can facilitate the epithelialization at the end of the healing of the ulcers. Okay, so I think,
Muhammad,
yes,
one
please.
comment is that the relation between this gel, Mina, and the contact lens, we can use it with the contact lens because of the carbomer. And when I used it, I was using it 3 times daily, especially in the first day post-op. But I found that no need. It's if you use it nighttime, it will be more than enough, especially for those patients that in the first 72 hours.
Thank you very much, Dr. Safwan, for this question. I also wanted to comment on this, on the contact lens wearers, especially with your first question about the 2 groups with the contact lenses or Rekugel. First of all, Rekugel cannot be used on the contact lens because it has preservatives. So it cannot be used with contact lens wearers or along with the contact lenses that are used post-operatively. So what we think is the best, what is recommended is to remove the contact lenses and use Rekugel, and after 15 minutes, the patients can put again their contact lenses, but it cannot be instilled on the contact lens. So this is for contact lens wearers in general. For post-operative, it also cannot be combined with the contact lenses that are used for bandages or to promote healing. So it can be used before applying the contact lens and after removing the contact lens to continue with the process of wound healing, but it cannot be used on the contact lens itself because it has preservatives.
Thank you, Mina. It's very nice information and excellent presentation. Thanks a lot. Now we will move to our second part. Thanks a lot, Mina. We'll move to the second part of our meetings today, and we are going to today to cover, as we announced, we will do a wrap-up about the cataract step, pros and cons on different steps. We know that we have done one session before 2 weeks, and we are not repeating, but we are trying to have more and more and dig deep in all steps of the cataract steps so that we can learn more and more and get more information and help us in our practice while doing the cataract surgery. So we will start as usual from the incision. We want to talk about different type of incision that available and or doing while we are performing the cataract surgery. And what are the effect of this incision? It's the benefit? What are the different types, different locations, different way of doing, and also how to do it without having also a leak while you are doing performing other part of the cataract surgery. I think we can have Dr. Safwan to give information about this one, and dear colleagues also, they will participate and ask a question and share their information.
Good evening, Dr. Muhammad. Good evening, everybody. Hopefully that I will be informative in this webinar and short and as possible as I can. So the incision, as Dr. Muhammad the importance of it, it's not that we are thinking that we will go to do it on 90 because we are used to do it, or in 0 or 180 because it's easy to do it and easy to go in, and that's all, without considering the few things related to that incision. So we will start with the cataract incision, the shape and the size and location, as Dr. Muhammad mentioned, and its effect related to the astigmatism correction intraoperatively. Now, intraoperative, so regarding the shape and the size, I will show you all the details, how we can preserve and create an incision with a shape that prevent any leak. And the size of that incision, that should be compatible with our phaco-tip and compatible with the injector size, that it should inject the lens easily without enlarging the size or going the tip inside the eye, and that will lead to, at the end, leaking of that incision post-op. And the effect of the location of this incision and what the surgeon should estimate its inducing of the astigmatism, because each incision in the cornea having an astigmatic induced, and that induction of the astigmatism depend on the distance from the limbus and the size of the incision and the location related to the steepness or flattening side of the cornea. So intraoperative astigmatic correction, we will discuss it here, especially for those that they are lower than 1 diopter, by discussing the main incision location to the steep axis and what's the steep axis, and main incision at the steep axis with LRI or by only LRI. And now, in my opinion, the best incision that we can do it, 45 degrees started and then horizontal through the cornea and then 45 in intraocular. This kind of incision that I choose it in a way that it will prevent the leaking. And unfortunately, I will not be able to show it in the movie, but I will try. But that incision, if we can see here, from the side extraocularly, it passed 45, and then that's what I'm personally doing it, and I'm very happy with it, without any leak. And start around less than 0.5 millim intracorneal, intrastromal, and then 45-degree intraocularly. This is the shape of the incision that I prefer it in my work. Maybe others, they are preferring perpendicular to the cornea and then horizontal in the stroma and then again perpendicular. But I found that this kind of incision, when it be perpendicular, it can be tear when we are implanting the lens through our injector, or when the manipulation through the phaco-tip increased or elongated more than for, let us say, for example, 5 minutes. So we will have tear, and that I saw it in post-op by using the B-scan. But here I will not show few technical issues that Muhammad, he was nagging on my head. Don't show things that maybe it's not available for others. So I will not show that things. So we can, using this kind, 45 entrance and 45 into the cornea and 45 intraocularly with a horizontal shape, that will secure the incision. Now, location, we said that the location of the incision is very important, and if we will ask all our colleagues, they will say, you need to go to the steep part. Okay, so in each patient, we are searching for the steep axis. But steep axis here, when we are searching for it, there is a lot of theory now around it. Now we will take a steep axis on the anterior corneal map, or steep axis starting from the biometric calculator, or steep axis taking from the aberrometer. I think that now the steep axis having a lot of modification, but still we can take it as simple from any corneal map showing the steep axis on it. For this steep axis, why we need to find the steep axis? Because our incision, if it is on a steep, this will reduce or flattening this steep, and by couple effect will reduce the astigmatism according to the distance of this incision from the limbus. If it is 1 millimeter or 2 millimeter, the more the near, the more the induced. So each surgeon having a number, that number should be fixed, because that depend on his experience to which astigmatism that he will induce when he is entering. So either steep axis or flat axis. So if we are passing through the steep axis, we will reduce the steepness by around, let us say, for example, in my hand, I'm reducing it about 0.25. If we will go to the flat axis, like for example, the steep axis was on 90, but the surgeon, he used to use 0 or 180. So here in this, he will steepening the steep axis or around 0.25. Now, if we are using the flat and the steep, we will not change the axis. But if we will use oblique and the patient having steep on 90, we will even change the axis of the post-operative astigmatism. So we need to be careful when we are dealing with the steep axis. We need to find out the steep axis. And going through the steep, if it is possible, or going to the flat, and consider the amount of the steepness that we need to correct it. So one of the important things that I'm doing, I'm correcting those that they have, for example, below 1 diopter by manual aspect, either by putting the steep axis on my incision on the steep axis and doing cornea relaxing incision as shown here on the other side, or doing cornea relaxing incision on the steep axis using either gross marking or digital marking. And that corneal relaxing incision, it's usually putting on the steep axis, and I have many nomogram that I'm using it that assist me in identifying the steep axis and calculating the size of the corneal relaxing incision as an arcade, and how many corneal relaxing, like for example, 1, or I need 2 to cover that diopter, and the distance of this corneal relaxing incision from the limbal area. For me personally, I'm using 1 millimeter from the limbus, means that on 9 millimeter diameter, not 8 millimeter. So I'm using a special nomogram for that to correct those with below 1 diopter. And that's the effect of the corneal relaxing incision. It will not affect the final spherical outcome because it acts on a coupling effect. The coupling effect is flattening the steep and steepening the flat, and the final spherical equivalent will be equal, so the spherical outcome will not affect it. Now, simply the limbar relaxing incision, I'm using simple nomogram. That nomogram show that 500 to 600 depth blade in 1 o'clock, means that 30 degree can correct below or around 0.75, and that's what I'm using. So I need 2 corneal relaxing incision to correct around 1 diopter. And this nomogram shows again age and the amount of the diopter that I can correct, but I'm usually like the toric lens in those that they have astigmatism above 1 diopter. But I can correct it manually for those that they have astigmatism below 1 diopter using the steps that I explain it. And that's another nomogram that I'm using in AMO. It helps me because sometimes I need more than 1 nomogram to show me the exact, especially when sometimes patient cannot afford a toric lens and he has more than 1 diopter on against the rule. So I need to go through and doing and looking to more than 1 nomogram to assess and to assess the axis and assess the power and the arcade of the corneal relaxing incision to put it. Now, I'm using Baratoric Calculator, and Baratoric Calculator is very simple. This is the site on the web, and any surgeon can go through. It's free, and can go through this one. This is directly from the web, and then the page will open this form. Any employee can submit all the information related to the patient in these data. Like, for example, here it's my information, and the incision site, it's very important for the surgeon to submit the incision site, whether 90 or 0 or 180 and so, and the induced astigmatism that each surgeon should have his personal induced astigmatism according to the size of the incisions that he's using it and the distance of this incision from the limbal area. And then at the end, he will have this calculator will show exactly the amount of the toricity. You can see it down in the last arrows. It's around 1.5. And for example, let us say this patient, he needs a toric lens T3 1.5, and the axis of its, it gives in the map and show that the axis of this toric lens 174. So in this way, from this side, if that patient not afford to pay for the toric lens, the surgeon should have the ability to do a corneal relaxing incision. So here in this way, I will go to my nomogram and I will try to put that corneal relaxing incision with its arcades on and the distance from the limbus to correct as much as possible here. Now, what's the important point in this calculator? First, the power that it's different than the power of the steep. If we will go up to the steep axis, steep K, which is 41.8 at 164. But if we will go to the calculator, we will see that the calculator give us an axis of 174 because most of our patients that they are above the 45 or 50, their axis will migrate toward the against the rule. This calculator will exactly give us the amount of the migration of the axis. For example, in this patient particularly, the migration will be around 10 degrees with the rule. So, sorry, clockwise. So 164 is the steep of this patient, but the calculator give us the axis of 174. If we will calculate here, this is against the rule. And Barrett, having a theoretical map, an equation coming mathematically, it shows that against the rule, it gives us, if we will calculate it manually under correction. So the calculator will give us around 0.75 over the manual calculation. For example, if we will ask Dr. Muhammad now to calculate how much the steepness here, he will calculate it as around 0.75. But if we will treat 0.75 for this patient, we will end up with 0.75 residual. So the calculator will give us exactly that this patient, if we will treat against the rule, we need to treat over correction in about 0.75. If this patient having with the rule, it will be under correction in about 0.5. So the calculator will give us the result, and we can go through, and personally, I trust the Baratoricity, and I'm using it in all my cases. That's all an example, and these are, for example for the one diopter residual and one diopter. Sometimes it's not available, or for a toric lens like T2, and the patient is not, or patient's not afford, so I can do it by using either using the first step, putting the incision on the steep axis and cornea relaxing incision from the other side, or two cornea relaxing incision according to the condition of the patient. So really, I love the toric lens, but in for those that they have toricity above 1, but for those that they have toricity below 1, I like to do a cornea relaxing incision or putting the incision site into the steep axis that appear from the calculator. Now, this is the movie, and I will show only one step in this movie, and then we will stop. And I'm using digital marker, but I show you that I can use the gross marking. And here, the digital marker showing that the steep axis, later on it will show, I have it. And that's the paracentesis, but we can see the main incision. It's 40, and then directly to the stroma, around less than 0.5, and then in. I will stop it here, and I will give the microphone to Dr. Muhammad. Yes, Dr. Muhammad.
Thank you very much, Dr. Safwan, for this excellent and clear showing the type of the incision. And you go very deeply on the IOL calculation, or about the toric lens. Okay, so if there is any comment from any here of our colleagues, Dr. Yahya, Dr. Hassan, Usama, Dr. Prasad. Yes.
Yes. Thank you, Dr. Safwan, for this nice explanation about the corneal incision. Actually, the shape of incision that you make it, the one I prefer to use it. I have also some videos about the 3 steps. I can show you the steps exactly, but I want you
to
stop
share, Dr. Safwan.
Okay, done. Okay, my dear.
Okay.
So you agree with me about the 3 steps?
Yeah. Most of my cases are 3 steps.
Is there anyone doing something different? Let us ask in this way.
Yes.
If you are the same, so okay, just to show us very fast, Dr. Hassan.
Yeah, this is a very short video about the 3 steps that the incision should be peripheral enough to be neck with the limbal vessels. The keratom should be slightly vertical, then go with the curvature of the cornea, then enter the anterior chamber, go with parallel with the iris. Now this is incision without hydration by the end of the surgery.
Exactly.
Without hydration, there is no leak.
No need for hydration sometimes.
No
most of the time, especially in in simple, let us say soft lens, no need for hydration.
Also, I have another thing I want to show you about the patient corneal incision,
which you have shown just now. So it's a two-step, not a three-step.
No, it's a three steps.
You haven't made the groove.
No, it should be slightly vertical over the cornea.
What Dr. Safwan has explained in three-step incision.
45, then straight, then
it's a valvular incision where you have to make a groove at the limbus, which should be at least 1/3 depth of the corneal thickness.
Yes.
And it should be straight, vertical, and then you put your knife.
Horizontal.
At the label of at the deeper label of that incision, and then go parallel to the surface of the cornea, and then add the 45-degree into the anterior chamber. That is called as a valvular or three-step incision.
If you see here, now it's vertical. Now it's vertical. Now I change the curvature of the.
You have already entered. So this is not a three-step. This is a two-step incision. It's very clear.
Exactly.
This is a two-step incision. Dr. Sir.
Okay, but I disagree because I put
three-step. You have to make a groove first.
Yes. You have to make it slightly vertical over the cornea. The first step. Then you will go with the corneal level. Then you will go enter to the anterior chamber.
It's a two-step.
I think it's this combination, by the way. Just because I agree with it. If you have all the wound three-step, you have to do a groove. But this is just part of the wound is three-step. Part of it's not really 100% three steps. Because the wound, when you go the blade horizontal further, you will cut it more of the first step will not be as a step.
Yeah, here also another case of patient with radial keratotomy. This patient also has dense cataract. In this patient, there is about 14 cuts in the cornea. So also it's very important in these cases to avoid the intersection with the corneal cuts. Let me show you this video also. In this case, I try to find a good space between two cuts to enter the cornea in 2.2. But what happens with me here in the step of IOL implantation, the radial cut was opened. I did sutures for the main incision, also for here you can see the opening of the radial cut, and also for the radial cutting. So in those cases, I would prefer to do the scleral incision better than corneal incision. That's what I want to add for the
I do agree.
Dr. Hassan, you have very nicely shown, because this point is very important, because in radial keratotomy cases, you have to find out a place. You don't have to go for the steep or flat axis. You have to look for the area where your incision size is within the two radial cuts. If it's not available, then you have to, in first hand itself, you have to go through the scleral incision, not the corneal incision.
Exactly.
Even so, Dr. Rajendra, even if you try with that, but it's not a guarantee that one of the incision will not open. And in my hand, I had one open, and the second time or third time I tried my best to go back or to go through that, but still the second, not the second, after a few cases, I had one with the manipulation. You can see the incisions start to be very loose. That's the radial, one of the radials start to be it's away from your side. You didn't reach it, but it start to be loose. Anyway, it's a very nice for Dr. Hassan to show us the radial keratotomy.
Okay, that's it.
Okay, Dr. Muhammad. Dr. Muhammad, you are mute. Dr. Muhammad, you are mute.
I don't know who mute me. Maybe you, Dr. Safwan. Anyway, okay. So is there anyone can give any other points, something different? So we have to move very fast, please, because we already went. Dr. Yahya.
Safwan says just basically incision is nowadays, because all cataract surgery we still to think about as refractive. So that's the message from Dr. Safwan, that always think about the stigmatism. If you can improve it, but most important, don't make it worse. That's what my message really is. If someone had a stigmatism and you make the incision -1, that will make it worse. So if it's like 1 become 1.5 or more, that will not be good for the patient.
Yeah, that I think this is the most important conclusion about the corneal incision and cataract refractive. Dr. Yahya, if you have anything before we move to the second step.
I think we should move, but the one important thing is that the construction of the incision helps in sealing at the end of the incision, but you have to remember that the size is important because you are getting around the structure through. So if it is tight and you work for a long time or you get a corneal burn, the wound will be leaking regardless of how you constructed it. So you have to make sure that you are not inducing any corneal burn and it's not a tight wound that you are rounding it more than it should be. This is my addition. And
okay, thank you.
Move on.
We can move to the second, things. I think capsular excess and hydrodissection. Dr. Yahya, please.
So, do you see my screen?
Yes.
Okay, I'm just going to, as we agreed, just to stress on points, and then we have discussion. So, one of the most important steps in cataract surgery, phacoemulsification, is capsular excess. And for a beginning or a experienced surgeon, it should be reproducible. And to be reproducible, you have to have in your mind a set of sequence and set of rules. I will give it, I call it the 4 golden rules, is that you have to have a deep anterior chamber, always with whatever type of viscoelastic, you can put it in many times to keep the deep anterior chamber, because you always want to have your forces with the forceps is the only player. Otherwise, you'll have a pressure gradient between the vitreous pressure and the pressure in the anterior chamber that will create a vector that takes the rexus to the equator, and this is why it extends. So first rule, deep anterior chamber. Second rule is to hold near the tearing edge. Third rule, to be repeatable, you should move in systematic way. So my recommendation is move every 2 clock hours and regrasp. 2 clock hours and regrasp. During the regrasping, you check the anterior chamber depth, you can replenish and increase also some viscoelastic. And this helps you to bypass the area of the sub-incisional where it normally extends, because the flap gets kinked to the equator and you lose some viscoelastic. The fourth rule is always bring the flap to the center. So as always, to see the edge to tear it. And the fifth thing is to have a high magnification. So let's see that we can do the capsular axis. To get it around capsular axis with the proper side should be round. It should be continuous, most important. You can do it with needle, and you have to learn both. And you can see how there is a trick that I do a second bend off axis of the needle. This will solve completely the problem if you are used to do it with the needle, the sub-incisional area. And the rules are applied whether you are using the capsulotomy needle or you are using the capsular axis forceps. As I showed you, the bend is very important, deep anterior chamber. And usually your intention is to have a 5 to 5.5 millimeter rexus. You can see here, viscoelastic injected. Rule number 1, enlarging the incision, holding every 2 clock hours. When you get more experience, you can connect 4 hours. But you see, wherever I reach under the incision and I see striations, this means I lost some of the viscoelastic. I restore the rule, deep anterior chamber, and then regrasp. And continue. Always the flap, you bring the flap to the center. The flap is brought to the center. Here I'm holding near the tearing edge. The whole idea is that you want to have a controlled way of rexus at any type of cataract, whether soft, even hard, and we'll discuss about this. It's very important to have the rules, to understand what you want to achieve. You want to achieve a continuous rex opening in the anterior capsule. You control its size and even its shape in a systematic manner, and you avoid complications by abiding to the rules, that understanding that you have to have a deep anterior chamber, understanding where you should hold, understanding how the flap should behave. And this, all of this can be helped as well with high magnification. When you work with high magnification, you can really see exactly what you are doing. Even if you get into a smaller, like this pediatric cataract, smaller pupil, you can apply the same rules. And any type, it's completely repeatable. Pseudo exfoliation, the same. You control and you see what you are doing. You understand what you're doing. If you are a beginner, you can lose some of the viscoelastic from the incision. So just stop, put again viscoelastic. Don't be deceived that you have gone a good excursion, 6 hours, 7 hours, and then you have the extension under the rexus. If you do this, if you follow the rules, it's almost always impossible, even if you are a beginner, to have an extension of the capsular rexus. Intumescent cataract, this is the last thing I'm going to show, has a different thing that it needs to modify some of the steps just to be able to avoid extension. And maybe this will be a point of discussion. I'll stop here not to take too much time and give my colleagues a chance to to show their technique in intumescent cataract. I'll stop sharing so as to
thank you, Dr. Yahya. Thanks a lot for this nice presentation and explanation how to do the capsular access. There is certain points I want to first to highlight about bunching the anterior capsule. How do you do? I mean, it's vertical, horizontal, according to your incision. Is there a difference or not about that one or not? If this is affecting, especially in the normal. Let us now talk about the normal cataract, not a mature cataract.
The question is, does the incision site matter with the capsular access?
No, I mean, when we are entering to the anterior chamber and we want to bunch the anterior capsule, cutting the anterior capsule should be horizontal, vertical, there is a way, or it's affecting or not affecting.
It really doesn't matter, but you make it the simpler, the easiest way to the surgeon. Usually a small neck horizontal makes it easier just to push it as to raise a flap. What you need to do is just to raise a flap. And for beginners, sometimes when they do this, they will scratch the cortex, and this will affect the visibility. So the best thing is just to inject viscoelastic, get away this cortex, and look where you are. Don't start in the periphery because it may extend and it will be more difficult to retrieve it.
Okay. Is there any comment from other colleagues here? Dr. Prasad, if you have any comment or video to show different things?
He has just left that intumescent cataract part, because the normal capsular access in a normal case where you do not have the capsular degeneration or capsular discoation. So in this situation, because the capsular access was Dr. Has shown just now was beautiful. Like he has shown so many videos, and it was really beautiful. Like the way you have to catch the flap, where you have to catch the flap. So these points are very important, because, and then you know that capsular access is a visual impression, because you do not get any feedback of the vector forces when you are making the axis. Because when you are holding the flap, you do not get any feedback, like how much pressure you are putting, where the axis is going. You have to see it. It's a visual impression, because how you are going to move your capsular axis is all on your visual impression. So the points of pupillary dilatation, your illumination, and your microscope setting. So all these points are very, very important. And the one important point which he has missed is the staining of the capsule, which is very, very important, because for the initial or the beginners, I would always advise them to stain the capsule, whatever is the type of the cataract. Stain the capsule So you will know your visual impression is going to be much, much better because you know that how the capsular axis is progressing. You will never land up into the capsular axis extension or tear. So your staining of the capsule, which is very important because this is one step which is very important. Otherwise, in an intermittent cataract, which is very, very important.
Okay, you want to show us an intermittent cataract or any other comment? Dr. Usama, you have any comment? Dr. Khalid, Dr. Safwan?
Yes. Yeah, as I mentioned, visibility is very crucial. So if you have any visibility issue, concern, using staining, that's definitely yes. But I think when you had good red reflex, you don't need the staining really.
Yes,
that would be very easy to see really, even for beginner.
Maybe even for the beginner, you mean, Usama?
If it's very good red reflex, mild cataract is very simple to see, even for beginner.
For beginners, I've had teach so many people to start phacoemulsification. I've never advised to use it's a point. Some people like this, but it is not a must. I did not forget to use the staining. I don't like to use the staining. I don't like to use any chemical when it is not needed. More important than staining in such cases is magnification. And this is something I always stress on my residents and fellows, that magnification is more important because you understand exactly and you see exactly how the capsule behaves and also at any step of the surgery.
Sometimes, Dr. Yahya, even in are doing a lot of magnifications, sometimes it will run from your eyes because of the pressure, or you are moving the change of the view. I mean, you are doing little bit pressure, you feel that you cannot see easily.
And the opposite, Dr. Muhammad, and you're never, the magnification that you are acting at the point, as you saw in my videos. But the magnification with all new microscopes, you have a good field and good perception, depth perception, not like the older microscopes. And actually, with the high magnification, and if we talk about complications, this is one of the main things I teach in preventing complications is using high magnification, because you always see what is happening at the moment. You never wait for secondary effects to say that you have a problem. So in my opinion, no, high magnification is very helpful, much more helpful than staining for immature cataracts.
Exactly. Dr. Yahya, just 1 minute, if you don't mind. Dr. Yahya, you are using Zeiss microscope, right?
I use Leica and Zeiss.
Leica and Zeiss. So if you will go back to your movie, you will see that the reflex that you are using two dot lights that gives you the red reflex of the back. So you are doing an excellent visualization for the capsule. And I do agree with you. If those that they have this ability in their microscope, exactly, they will not be in need for a staining. But those that they don't have this ability and this facility, they will be able to see the capsule through a staining. So when you have the two dots, 100%. In my microscope, I can use the 3 dot, I can use the 2 dot, I can use 1 dot. And in 2 dot, you have the excellent red reflex that appear on the capsule. So you can do whatever you need in the capsule and you don't need any staining. But if you don't have this ability, you don't have this facility, yes, you need the staining. And that's my opinion.
Dr. Prasad?
Yes.
Especially like in most of the cases, what we are operating in India, they come at a mature state because a hyper mature, mature and
at the second
course. You don't get any red reflex. So you have to stain. So there is no choice because you have to stain the capsule if you want.
Yes, this is
we are talking in the mature cataract. I think everyone agreed.
We are talking immature now.
Yes.
I left the mature just to listen and see my colleagues' technique, and then I can comment on the technique on.
Who's going to show us the intermission, Dr. Hassan or Dr. Prasad?
I can show you. I will show you.
Hassan, if you have any comment before Dr. Prasad move to the capsule.
Yes, actually, thank you, Dr. Yahya, for these nice steps. Regarding to the staining of the capsule, it depends on the red reflex. If you have good red reflex, no need to stain. But in case of the cataract is brown, dense brown, no, and we can use the stain also in mature white cataract. We can use the stain. Also, I have many difficult cases in case of anterior capsular fibrosis. What are going? I have some clips I can show you. In case of intermission cataract, different types and different techniques. Also, in case of the peripheral extension in white cataract, intermission cataract, or in regular cases, what are going the little brain maneuver. Also, I have some videos, some clips.
Okay, so we can, what we can do, we can have Dr. Prasad showing his different way. If there is any different than what he's showing, then we can see. Okay, yes, exactly. So we have to use the time in a proper way. Okay, Dr. Prasad, yeah.
So I'll just show you a video where this is the intermission cataract, and this is the intermission swollen cataract. What you can see here, because I'm using a needle to puncture the capsule. The moment you puncture, the cut which I have made on the anterior
Argentina flag.
Okay. So this is Argentinian flag sign, and this is well-done situation like we come across in many of the cases. And this is the animation, how it happens actually, because now this is basically because what happens when you are using the needle, especially the hypodermic needle, this needle has a tip which is like a sharp tip knife. So when you puncture the capsule, it makes a linear cut on the capsule. And you know there is a high pressure within the capsular bag. Now this high pressure creates a force, which is a disruptive force, which actually easily opens up. If you make a cut on the capsule, it opens up the capsule and the Argentinian flag sign happens. So what I want to show is one video, not this one. Sorry. Okay, so I think this computer has gone away. I'll just take this to again, open it up, I don't know. So some problem has taken place. I don't know. This computer is. Okay, it has come. Now this is the technique which I have already published in JCRS. Now what I'm doing is I'm using a saving needle microcapsulotomy. Saving needle microcapsulotomy means you can see these two pictures here. The first picture is made with the hypodermic needle. You make a small cut in the cornea which opens up easily. So what we have done is we have devised a device which makes a hole in the anterior capsule. So if you can make a hole of this kind, so you can see here in the next animation, you make a hole. So if you make a small hole, it won't disrupt, it won't extend to the periphery. Whatever is the force inside, it will not open up and go to the periphery. So you can see here in this video now, this is the intermission cataract, and this is the side pot. And then I'm going to stain the capsule. So this is very important because you have to stain the capsule in this situation, because where you have an absolutely white cataract, you do not see any red reflex. You don't have the illumination proper, like because of the fluid. So this is the needle. This is a sieving needle. So the needle which is used to sieve the clothes, it's a round tip, and it's a circular round and pointed tip, unlike a hypodermic needle which has a sharp cut.
And is there a magnification to see how it looks like the tip? No.
Yeah, I'll show you the tip also. So when you puncture the anterior capsule, it makes a hole. So it has made a small hole. Instead of cutting the capsule, it has made a hole. So you can see the hole here at the center. And this hole now actually has a resistance against the pressure. See, it works like a mini capsular access. So we call it as micro capsular access. So you can evacuate the fluid through this hole easily with the milking technique. You do a milking technique, bring the fluid at the center, and this fluid will come out of this hole. And once the fluid comes out, the capsular bag relaxes. It becomes a decompressed. And then from this hole, you can make a small tear and then start the capsular access. I'm using the Rex's forceps, and this is how you can start the capsular access. Keep holding the tip of the flap, go around slowly and slowly. So we don't need very high or very large thoraxes in this situation because the cataract generally is not very hard. They are soft cataract. So you don't need too much of manipulation. You can very easily remove these kind of cataract with this is how you can make a capsular access very successfully without having any extension. So this is how you do this, and then you can complete the surgery. You want to see the device?
If there is any magnification.
I have the animation, but not in this video.
Okay, we can go move to the next other colleagues. Later on. While we are discussing, you can just prepare it and show us. That's okay. Okay, so Dr. Yahya or Dr. Khalid, Hassan.
Hassan. Okay.
Yes.
I want to add something about the technique of Dr. Prasad. Thank you for this nice technique. But I think in this case, if you don't decompress the eye, the lens pressure properly, the peripheral extension is high in those cases. And can you stop sharing, please? Okay. I want to show you another two different techniques in a case of intumescent cataract.
Okay, if you can, Dr. Prasad, just stop share and check for the video. Later on, we can have it.
This is
okay. Can you? Okay, Hassan. Hassan.
Yes. In case of the intumescent cataract, the technique that I prefer to do is the double rexes technique. Double rexes technique, when you are going to do a small round rexes, and you decompress the intralenticular pressure properly, it's very important to decompress in all sides.
Can you see it? Can you see it when you are explaining on the video itself? So to know what you are talking about. Sure. What do you mean by double rexes? Okay. Can you?
Yeah, you let me back. So here is the needing the cystatome to create a small.
We are not seeing. The video is not showing. We are not sharing the videos.
Why?
Open the video.
Open the video. Video is not open. Just press on the video to open. We are seeing all the videos. Can you stop share and go back, Hassan? Very fast. Okay.
Share. Okay, the capsular rexes. Okay. Here a case of intumescent cataract. Of course,
now we
after
can see.
staining.
Okay. Can you go from
after staining the anterior capsule, here is the smaller central rexes, then decompress the intraventricular pressure. Properly is very important. Then a small snip with a scissor, micro scissor, and you can perform a beautiful.
Okay, Hassan, I want to ask you a question here. Yes. How do you, the most important, we want to know the trick. You know, when you are doing this one, it will, when you are doing the cut itself, puncturing, maybe immediately it will go. That's what we need. How you will do the first one.
Yes, as mentioned by Dr. Prasad, you can go central and do directly small flap, directly rounded. Don't make incision. Don't make. I will show you. I will show you another incision. I will show another incision how the retinal flag happened. So here is the second case, intumescent cataract with pseudo exfoliation. In this case, I used 27 gauge needle connected to aspiration tube of the phaco machine. Here you can see I go through the paracentesis, go directly inside the lens, then aspirate the liquefied cortex. Now I decompress the eye, the lens properly. Then I open the 2.2. Then I do the usual capsulorhexis without any risk of peripheral extension. I will show you another.
Is there any other different techniques? We want to concentrate on different way. If it is similar, almost we get it. Now we want to see, I think Dr. Yahya, he have some tips on that. If you have something, Dr. Hassan, we can go with you. Sorry.
I have some videos about the anterior fibrosis of the capsule, anterior capsular fibrosis.
I mean, let us get it on the normal one, then we can have another one. Okay, I'm sorry. Okay, Hassan. Can you go, Doctor? Yeah.
Yes, I'm downloading the just because it's. But I want to
till you finish, Dr. Yahya. Yes. Okay, sorry.
I just want to stress something important. All the techniques are mentioned are nice. The instrument Dr. Prasad made is nice. But again, we don't need instruments. We need understanding what is the problem. That's why I said the rules are the most important. What is different in intermission cataract? Why it extends? Because there are variant and normal. So the pressure inside the eye, the lens is high. And that's if you make a neck, it will extend. So logically, what you need to do is to restore the rule. Number one, is always to keep the pressure in front and behind the capsule equal. How you can do this? So in my opinion, in my technique that I hope I can show it, just the beginning of the incision. Of course, all the techniques, the double capsule relaxes, the mini relaxes, like Dr. Prasad said, are good. But in my technique, it's reproducible. So what I do, I just do an incision and curve it immediately and stop and go out. If it extends, it will extend where I want. Then I will tackle the problem. I will go inside the capsular bag and aspirate cortex and then inject viscoelastic to equalize the pressure in front and behind. Then I can do the regular, whatever difficult case you have, you want to convert it into a normal case. So in this way, it will not extend and you can repeat aspiration while you are going around. So this is a technique. If you follow it, it's almost, almost impossible that you will have an extension. Once you understand what is going on. Do you see my?
Yes.
Just a second. We can.
Okay, thank you for the information about Nigeria and Liberia, Doctor.
I just need to comment, but I said that you don't need to disturb him. He's selecting.
It's 1 second now.
1 second, yeah.
Just,
in 2 minutes.
But you can discuss whatever points you want, and I will just.
Okay. If there is any comment, Dr. Usama, you are there.
Yeah.
Usama.
Okay.
Yes, I am here.
Yes, Usama.
Just waiting for basically what Dr. Yahya says is correct. When all colleagues they say correct, it's just basically it's very important to have a good pressure. So always maintain high pressure in the anterior chamber. When you have these things, I prefer to do needle aspiration straight away. I don't think you need to have a phaco machine connected. With the syringe, it should be very straight, easy also.
Same syringe. The same syringe.
I don't use the phaco machine as a setting to do that. And just try to smaller capsules and extend it always will work easy for any case really.
Okay, Usama, just with you, Usama. I think we are having a different way or different technique, so everyone, can learn different way, not only depending on one type. That's the aim of our meetings.
Definitely.
So there is a different way. I think Dr. Prasad way, and another one which is an excellent also innovation about this one, which is just a small hole round. That means it will be easy. From that you can go and do, I think, suction of the liquefied material. If that's okay, Dr. Prasad, you can go through that hole.
Yeah. I'll show you the device.
Okay, I think Dr. Hassan is here.
Can you see my video?
Can you repeat, Doctor? Repeat it again. Can you start from the beginning, please?
No, this is the most important step.
Okay, go back.
But the most important is to, you see, it's curved. I curved. If you curve it, even if it extends, it would go where you want. Then you aspirate to decompress the bag and inject viscoelastic, and you can repeat the step as much as you want. And I disagree with Dr. Prasad that white intumescent cataract can be white, and this is easy that you can do as a phacoemulsification part, but many of them, as probably I'm sure he sees in India, are brown like this case. So if you have a harder cataracts, and with this technique you can control the size, actually you need to be on the wider side rather than the smaller side. According to the nucleus, you can control the size even in intumescent cataract.
So okay, can you just repeat?
Spiral.
You see the curve?
Spiral capsulotomy.
Here,
okay, Doctor.
You see the curve?
Dr. Yahya, I think I have seen this. Can you enlarge? Can you make the show? The video is in a show way, not in the slideshow. Slideshow.
Okay, sorry.
Okay. Then I want to ask you. If you have, a slow movie that we can see, how do you do?
See, here is the curve. It is
okay.
Curved.
It is a curve you make it by a curve, a needle, or you start then curve it?
With the needle, I don't bend the tip of the needle. I make it always like a knife, and I just curve and push it. You see? Then you can control, and whenever I lose, you see the striation? This means the pressure in the anterior chamber is getting lost. So I inject viscoelastic to restore the rule number 1, to have a pressure equal in front and behind the capsule. The whole trick is to have pressure in front and behind. Second trick is to see, and you can stop at any moment to restore the rule. You can see, you can stop.
I want to see again, Dr. Yahya, how you do the curving. This is the most important. Is the tip is
I just want.
Okay, no problems.
Can I add some comment for Dr.
Yes, Dr. Hassan, go ahead.
Yeah, this is a spiral technique. Yes, I agree with Dr. Yahya about this. I was used it many times, but in this case, aspiration the liquefied.
This is not spiral technique. You see here, I'm afraid. You see that
you make it 2 times. You make it two rounds.
You don't have to.
So in this case, if you don't aspirate decompress the intralenticular pressure properly, the peripheral extension can be happened in these cases.
Well, this is what I'm saying.
That's why I want exactly to see how it's done. It's the most important.
So the most, So in my opinion, I think double Rix's technique, you can aspirate the liquefied cortex, you can decompress the lens properly in all sides, you can press also pressure over the nucleus to let the liquefied cortex behind the lens, the nucleus comes to the cannula. This is my comment.
Actually, the point is because you have so many techniques, but Argentinian flag sign still happens many times because whatever
of course
is the aim is to minimize as possible.
Whether spiral technique, whether you use a microcapsule, which still happens. The point is, the Argentinian flag sign will not happen in each and every case. They are not meant for the Argentinian flag sign. There are certain cases where there is an optimum intralenticular pressure, which bursts and goes to the periphery. So these are the situation. Even if you make the cut on the this video is seen here because you are making a cut with the needle. This is lucky, like you didn't have the Argentinian flag sign in this.
No, it is not. I'm lucky. It is not lucky. It's a reproducible technique, Dr. Prasad.
You do the same technique. Another case, it will happen.
No,
I think let us agree on a point. I think Dr. Yahya, can I comment? Can I comment, Doctor? I think Dr. Yahya is insisting on a certain point that whatever he is doing, he is, I mean, he get rid of Argentina flag by he's having a very high pressure in the side, the eye. So this is the most important. I think that's why it's whenever the pressure off. So, can we mute John? John, can we mute Dr. Mina? Please mute Dr. Mina.
Can I show you the device or device?
Okay.
Dr.
And close the
device. Yeah. I'll show you the device.
Doctor, yeah, it's an excellent technique. Really, I did it many times.
But I want you to hear. I want to hear you. But I know you want to say this one. Why not?
I want to show you one case.
Let us see, Dr. Prasad.
This is the device I'm showing you. This is the device we have invented and already patented. This is the device called as a micro capsulotome, and you see the tip of this device is round and circular. It's not like a needle. It's a round. Tip is pointed and round. So when you puncture the capsule, it makes a hole. Yeah. It makes a micro hole.
Is it sharp in the whole area? Is that so?
Yes. Sharp when it enters, it makes a hole. Now this hole is like the microcapsular axis.
Yeah, I'm using chopper. I have a chopper like that, and I'm using it.
Yeah. It's
okay. There is one comment. I think we need to. There is someone asking if we can use the phaco tip to do the capsular. I mean, to puncture of the anterior capsule.
Phaco tip? No. Yeah. No, I don't think so.
Some people do. The idea is to have something reproducible. Yeah. And I agree with Dr. Prasad. If you puncture with the needle, you can get the extension. I don't puncture the capsule. I cut the capsule. So there is a difference. So when you cut it, you can control it because before the fluid is released, you already have done the curve. And this is a technique that is completely reproducible.
Yeah. So Dr. Yahya, you are redirecting the Argentina flag in your curved way.
I'm preventing. I'm not redirecting.
I know. Yeah, I know that you are preventing.
Yeah, preventing in the way. Doctor. Yeah.
The direction of the incision, even if it will continue in a curved way.
Yes.
Like round way.
Okay. So may I show you?
Okay, can we see? Okay, Dr. Hassan, this will be the last video. Then we have to move to the next, please, as we are already run behind the times. Okay, anyway.
So the next will be
1 minute, Dr. Safan. No. Let us listen to Dr. But 1 second, Dr. Safan. I don't know. Next step, it will be hydrodissection. Then we will go to the phaco shop. Okay.
Okay.
Yeah, it's
So Dr. Hassan need to prepare the video before. Okay.
We can go to. I can share it later. Okay, no problem. I stop sharing.
No, why? If you found it or not?
No, I find, but I will look for it. I need for about a few seconds.
Okay. So just have a look. Let's move to the hydrodissection. Can we start with Dr. Prasad? If you have what is the technique?
I'll talk on the chopping.
Okay. Let's go for Dr. Yahya or Dr. Safwan if you have.
I have in the movie, but it's a different way. Let us, Dr. Yahya, start.
Okay. So you lost your time, Dr. Safwan. Okay, let's go, Dr. Yahya. Okay, Dr. Yahya.
Because I have it in different technique. Yeah.
So the whole idea of hydrodissection, again, you need to have. Is my screen shared?
Yes, it's seen. Can you just make it slideshow, please?
The whole idea is that you want to have a reproducible step, very easy. So what I teach, you have to tell your resident and you as a surgeon to know what is the end point in a simple way. So after doing a proper capsular access, you go with the canal, go with the healing canal 20 gauge. I check the fluid outside of the eye. I go under the anterior capsule to the equator, inject one wave of fluid, as you can see here, going and making sure that this wave passes to the other side. Once it passes, you are properly hydrodissected. You can inject another wave. You don't have even to check rotation. And this is hydrodelineation for beginners to see how it is. Again, this is, look, it's very in a slow motion. The whole idea is you inject at one point at the equator, massage the lens because you don't want to have a capsular block as well. See the wave, and this is the value of high magnification. See the wave passing through the other side. It's not only passing behind the nucleus, you want to pass it from the other side. That's why you move diagonally from the point of injection to the other side, depress and push the nucleus a bit just to allow the fluid to pass. If you do this and you see this as a resident, as a surgeon, you will not need to see the nucleus. I never rotate usually the nucleus. I'm sure if I get the wave passing, I have good hydrosection. And this is one of the reasons I don't do hydrosection in hard cataract. If I don't see the wave, I don't do hydrosection.
Yes.
So look here, it will only take a few seconds in a slow motion. See the wave I'm talking about and where I press. You check the cannula outside, you go inside, depress, decrease the pressure in the anterior chamber, go to the equator, you see the wave enlarging. I go to the other side opposite, depress, and make the wave pass around the edge of the nucleus. Once you do this, you are 100%
done with
hydrosection. So
okay, Dr. Safwan, Dr. Safwan, can you show very fast yours? Yeah, please. Yeah.
I'm preparing the video.
Okay, can you go to Dr.
Just wait. I'm just
while
sharing.
you are preparing, we can talk, no problem. Or
share,
Hassan, if you can share your screen and show us what.
Yeah, but
no, don't share. There is no share. Go ahead, prepare yourself. Okay.
I want to add some comments for Dr. Yahya. Thank you for this nice tips.
Safwan, can you share?
Okay.
While we are talking, yeah. Okay. Go, Hassan. Yes. Hassan, can you continue? Hassan, you are. Hassan, I think we lost Hassan.
Yes. Do you hear me? Hello?
Yeah. We lost you. Yeah. Can you go ahead?
Now do you hear me?
Yes, Hassan.
Yes, I have two comments. The first comment, while you are go to do hydrodissection, the tip of the cannula, actually, I don't go to the equator just to be underneath the anterior capsule, underneath the capsular rexes, and at the same time, simultaneously, while you are doing continuous gentle injection of the BSS, at the same time, you have to press slightly at the lips of the main incision, main phaco incision. That okay. you will see some fluid go inside, some fluid go outside. This is the first step, and the second step is before doing, and as Dr. Yahya said, you have to test your cannula to avoid the flying cannula. Also, it's very important to empty the anterior chamber slightly from the viscoelastic before initiating the hydrodissection. Also, it is very important to prevent the to prevent high pressure inside the anterior chamber. And the third step is after you see the wave, it's also important to apply gentle pressure by the cannula over the nucleus to be sure that your nucleus go down to prevent the capsular block syndrome. That's it.
Okay.
Also, I have nice video I can show you if there's time.
Hey, let him continue.
No, please
continue.
No, Dr. Safwan, I am the one who's, can you go? Because there is no time, we need to finish, please.
Okay.
Can you show your step, please?
Now what Dr. Yahya show us is this is the ideal hydrodissection. But sometimes we might not have it. And we have a leathery cataract. So what we will do? We will still try? No. Here, I'm not doing that. Here, I'm stop, and I will show you.
Can you show us?
I tried, see? No, sorry. 1 minute. Because I was preparing till the end. So see here I passed my hydrosection cannula and I tried, but as Dr. Yahya said, I couldn't get the reflex. So I stopped, go to my chop. I have technique in a leather, see? Leathery cataract. tunnel in the center. That's like all the hardest part of the movie is very quick, hardest part of the center, then divided into two. Say, from this side, I divided, and then full, and then hydroid section. Here I did the hydroid section. In this way, I didn't create any stress on the nucleus, on the zonules, and easily I rotate. Here I divided more. I saw the wave, 100% it's guarantee. Yeah, say I moved, and that's all.
Okay, thank you. Okay, is there any comment on Dr. Safwan videos?
I just stopped the sharing.
Yes.
Can I show you?
Just 1 minute. Is there any comment, Dr. Yahya, Dr. Prasad, about or?
Dr. Prasad, we can hear.
Dr. Yahya has shown beautiful technique. Like if you are not able to do the hydrodissection in these hypermature or the leathery cataract, brown leathery cataract, you should not attempt. You should try to start sculpting the nucleus, and then slowly you can, even while cracking, many times the nucleus will become free. And then
so that's what I showed, Dr. Prasad.
So you have shown very beautiful. This is what you have to keep in mind in these high cataract. Rather attempting hardly hydrodissection, you can
exactly.
So you have to be very careful in these cases. Yeah.
Very nice. Dr. Usama, is there any comment or questions? Usama?
Usama, maybe he went to sleep.
No,
Usama,
no. I will let you
still
talk together.
Sorry, Usama. I'm very sorry.
No,
I'm very sorry.
When you don't, it's a hard cataract. Just if you do hydrosection, just minimum. If you do a small multiple mini hydrosection,
yeah.
But and then do the groove and try to rotate. If it's not, do hydrosection more.
Usama, my aim is to reduce the pressure on the zonules. That's my aim.
Okay, can we go Hassan now, please? Please. We need to move a little bit fast because the time is going very fast. I know the topic is very important and very nice.
Yeah. First, I want to show you the peripheral extension to the hydrodissection.
But if there is different hydrodissection, show us. If it is same, it's no need. So we need something different.
I want to show you the pressing on the. Okay. This empty the AC first, then testing the cannula. Then go just underneath, don't go to the equator. At the same time, look here to the lips of the incision. You can see at the same time, there's slight
pressure. You are doing a pressure on that, so the fluid is, I mean, the viscoelastic going out.
And by the end also, you can do the pressure over the nucleus to be sure that there is no block syndrome of the capsule.
Okay, can we stop here?
I will show you. Okay. I will show you only this is the peripheral extension, the one I told you about it. In this case, after decompress the pressure of the lens, and I start to do the rexes. You can see here, peripheral extension has occurred despite of decompression, because my decompression is not complete. This is I want to show you. That's it.
Also, maybe the anterior chamber maybe is not full. The pressure is too much. What? Maybe you have to fill the anterior chamber.
No, actually, I don't decompress the intralenticulaar pressure properly. Yeah, this is I reviewed the video many times. So after that, I was very cautious about how to decrease, how to apply pressure over the nucleus. Okay, to let the liquefied cortex go behind the nucleus. That's it.
Okay, I think we need to move now to the second step with phacoemulsifications, different phaco techniques, and I will give this to Dr. Prasad.
Okay, I'll share my screen.
Yes.
One comment about femtocataract, that also can be a good option, by the way, for Argentinian flag.
Yeah.
Revenge.
For
femtocataract.
Femto. Okay, yeah. Not everyone having femto.
I'm going to show you the chopping, a new chopping technique, because we have been using most of the technique like vertical chop, horizontal chop, and reverse chop. So many chops are there. But many times, because we all have been doing the chopping technique, and many times it becomes very difficult, especially in the rock hard cataract or the hard cataract or mature cataract or the leathery cataract, it becomes very difficult to segment the nucleus. So segmentation of the nucleus is very, very important in these hard cataract. Unless you get the segmentation, complete segmentation means full thickness segmentation of the nucleus, you are not able to emulsify. Then if you try to emulsify unsegmented nucleus, then you tend to use too much of forces, too much of high energy, which could lead to complications. So I have developed a new technique, which is called as a terminal chop technique, and it's very popular, and we have published in the International Journal and Indian Journal also. And now a lot of people are practicing in our country. The idea of this technique is like we have devised an instrument which is called as a terminator, that is chopper. So I'll just go a little forward this.
Friends, we know that.
And this is the chopper which we have. The concept of the chopper is it's like the wedge tool which has a tip which is like a wedge, and this wedge, when you hook the nucleus around, it gives you a cracking force, that dispersive cracking force. This is the chopper which is called as a terminator. You can see this video. When you hook it around
through the equator, it generates a tensile fracture force. Now this tensile fracture force cracks the nucleus through and through.
You don't have to cut the nucleus, it cracks. So cracking happens at the equator itself.
Free segments. Terminator makes surgical maneuvers much easier, safe and effective. And as you can see here in this video, how simply we can crack and break
just move to the periphery, hold it, hook it,
free segments
and crack. So you can see the cracking happens through and through, and you get a complete full thickness cracking of the nucleus. Whatever is the grade of the nucleus, you can very simply crack these nuclei into 2 complete segments, into 4 segments, 5 segments or 6 segments. For the emulsification, because it is a complete cracking. Now this is the full thickness cracking of a little softer, not the soft grade 1 or grade 2 nucleus. So I'll take you to the little harder nucleus. This one is, you can see here now, a little brown cataract, say around NS3, hard cataract, and you can crack this. So simply you can crack these nuclei into 2 complete segments. And NS3 nucleus again. Just hold the nucleus at the equator, within the equator, hook it, and then crack it. The cracking happens at the equator, and which automatically goes to the center and to the equator on the other side.
The biggest advantage of this technique, and
it can be used. Now this is a little harder cataract, Brunesen cataract. You can see this Brunesen cataract also can be cracked so simply.
Bring out the maximum.
This is how you can crack these hardest of hard nuclei into 2 complete segments. There's another Brunesen nucleus.
Phacotip is impaled distal to the center of the nucleus superficially, and the tip is directed towards the equator, so that we could place the phacoprobe at the equator just adjacent and parallel to the cracking device, so that you get the maximal cracking force. Once the phacotip is placed at the equator and the nucleus is firmly held, the nucleus is slightly drawn within the capsulotomy edge, and then the cracking device is hooked around the equator of the nucleus under direct visualization. Now, since the tip of the terminator is round and olive tip, hooking it around the equator of the nucleus gives no threat to the posterior capsule. At the same time, it takes the maximal mechanical advantage of transversal fracture force as well as the force amplification. Then simply drawing the apex of the wedge inner edge of the cracker tip easily crack the nucleus, which automatically traverses through the entire nucleus, enabling us to obtain complete full thickness segmentation of the nucleus.
Hardest of hard nucleus.
Dr. Prasad, I think it's okay. Just we have some question maybe for us. I think it's very nice and innovative and excellent. What is the power? I mean, how do you use? I mean, it is against one power against one, or put it and left what is the technique you are using? I mean,
so that is what I was trying to show in the animation video. Basically, like the idea is you are tackling the nucleus at the weakest part of the nucleus, the weakest part of the, or the thinnest part of the nucleus at the, just within the equator. Because if you tackle,
what I mean, when you are fixing the nucleus at the periphery, then you go there and you, then what is the power? You are straight, lateral, or just like a small, I mean, how you are doing that? I mean, or usually as we are doing the shop.
What you have to do is, it's absolutely different from the horizontal or the vertical chop.
Okay.
Here you are putting the phaco probe just proximal to the center of the nucleus, and you are entering the phaco probe not deep. In horizontal chop, your direction is posteriorly. You are going towards the posterior capsule or the vitreous. But here in this particular technique, you don't have to go posteriorly. Your phaco probe has to go parallel to the surface of the nucleus, a little deeper, not too deep, and you have to go towards the equator. And you have to stop just 1.5 millimeters or 2 millimeters, 1.5 millimeters within the equator, hold the nucleus there. And then you have to slightly draw the nucleus. You see the edge of the nucleus, then hook that device around the nucleus, through and through around the nucleus, hold it. Now the vector forces are going to be created with the help of the phaco probe here and the chopper here. And then the moment you bring the chopper, because it's a wedge, it starts cracking the nucleus. You don't have to cut the nucleus, it cracks, and then bring a little, and then you can create it 2 complete pieces of the nucleus. Like this, you can chop.
I mean, the phaco tip, it will be only fixing, or you have to make a power to rotate and make it.
Yeah, phaco tip is only to fix and give a counter pressure.
Counter against the effect of the other.
Against the chopper. Yeah.
Okay. Is there Dr. Yahya, please? Yes.
Yeah. Very nice, Dr. Prasad. But I'm one of the main proponents for vertical chopping. Vertical chopping, I use particularly Neuhan chopper, which is a very old chopper that had not changed over the years. It's extremely useful. I can even show you how it is used. But for the sake of time, unless you allow me, the idea why I like vertical chopping in any type of nucleus, vertical chopping, you always see where you are splitting.
Okay.
You can use the fixation with the tip as a fork, and the knife is the chopper. Even if the pupil gets narrow, you don't worry about going blindly with a vertical chopper like this one, blindly to the equator and then cutting. If you have zonulisis, you risk more. But with vertical chopping, you are actually under vision, doing every step, and you can split even the hardest nucleus down to the last fiber that is preventing splitting. So
can we see the horizontal, vertical, and we want to go to the horizontal?
Yes, I can show it.
I'll just answer you.
Yeah.
I'll just answer one thing. Is like any technique which you are using for any purpose, it has to be simpler, it has to be handy, it has to be like easy to use by the newcomers.
Yes, I agree.
See, you are an expert surgeon. Expert surgeon can very easily use vertical chop. I've been using, but you give the vertical chopping to a new surgeon, he won't be able to use. So he needs a very simple technique where he doesn't have to do too much of manipulation, too much of process.
Dr. Prasad?
Dr. Prasad, I think vertical chopping needs more experienced surgeon, because you go to a blind spot. The blind spot, unless you have very well dilated pupil, you are in a blind spot and you manipulate under the rexis near the equator. So of course, your chopper is nice because it is blunt from the back, so it is safe on the capsular axis.
You didn't take up my point actually, because in this terminal chopping technique, you don't have to go to the equator. It's the only phaco probe which is going just within the equator. Then you are drawing the nucleus. Your chopper is not going at the equator. You're drawing the nucleus within the capsulotomy edge. You're seeing the nucleus.
Exactly.
It's not blind at all. It's not blind at all.
Is it applicable for all type?
If it's a big nucleus, you cannot do this, Dr. Prasad.
There
is no space to grow the whole nucleus.
Big nucleus
is narrow, you cannot do this as well. But I agree with you.
And the nucleus starts tilting. It's a vertical tilt happens in the nucleus. You can see even any size of the nucleus, you can bring the capsule within the capsule mesh because it tilts. It gives a vertical tilt. That is the idea of holding the nucleus at within the equator, because if you hold the nucleus at the center and if you pull it, then you are going to put stress on the zonules and nucleus will not tilt. But if you are holding just at the edge of the nucleus and you draw it, nucleus starts tilting. You can very easily see the edge of the nucleus and then hook.
I agree. And it's very important for each of us to learn to be able to do both techniques, because many times I do vertical and then I do horizontal at the same time. So it's very important to learn both techniques. And as a younger surgeon, you can choose which is more comfortable for you. Nothing is 100% the best. The best is what you get you to the better results. And I think of course, we are discussing, but it doesn't mean that there is only one thing is right.
Yeah,
you can have both things.
All the techniques one should learn. Yeah,
I think Dr. Yahya, this, but we are having different way, and one way is what Dr. Prasad is an innovation, and it's very nice. Maybe also it's very good to learn. It's another addition to what we are knowing. Dr. Prasad, I have one question before Dr. Yahya starts. It's applicable also for the soft cataract.
Yeah, that is I told in the beginning, because not a very soft cataract, like it's a pulpy soft, which you call as a floppy soft cataract, it won't work, because there the cheese wire will happen. You can't hold the nucleus.
You can't hold the nucleus.
This will work where you can hold the nucleus.
Hold the nucleus.
Okay. Grade 3 and above. Grade 3 and above.
If you're not able to hold the nucleus, then it doesn't happen. This is basically meant for the rock hard cataract. Harder the cataract, this technique works better. Harder the cataract. That is the point.
Okay, thank you very much. Okay, Dr. Yahya, we can go ahead and show.
I just want to show the vertical chopping and my technique in hard cataract in another way, that the idea is to convert again a difficult case into a regular case. So you put down what is different in the hard cataract. It is thick and hard. So, and you don't want to use overpower near the cornea. So I do what I call two nuclei concept. I use bevel down to remove upper part of the nucleus. Then once I go down, as if it's a new nucleus, I turn the bevel up as normal, exactly. And then I work with the nucleus, as you are going to see. The whole idea is that in the two nuclei concept, that you create a crater that will enable you to see the floor well, which is one of the main difficulties in this thick nuclei. So, and we always have to have good exposure of the tip, and I don't use hydrodissection because I don't see the floor. This is very hard cataract. I can use stain, but here, because there was some red reflex, I do the capsular axis, and it should be large to allow your maneuvers. This is well dilated, but the same technique, the bevel down, you shave the upper part of the nucleus. If you work away from the cornea, you are not insulting the corneal endothelium, having visco-adhesive or visco-dispersive coating the cornea, as you can see with a very fine air bubble at the back of the cornea. And you create this crater, all this away from the cornea, and then you change the bevel down, because now there is good opening. It's like you are, look, I cannot بتبص من بير, a well. So you can see where are the fibers. And if it is very hard, I can weaken the nucleus. Again, you are working away from the cornea. Your main interest is to use the least effective power that protects the cornea in the furthest away point from the cornea. I'm working completely within the capsule, within the lens, within the capsule. This, I'm creating what I call hole drilling technique in harder cataracts to weaken. And then you will see how vertical chopping will work. You see, this is embedding. That's why you need high exposure, good exposure of the tip. You embed it, very low power, 40%, 30%, according to your machine. And you can see I'm splitting the fibers till the end under vision. And the pressure is going towards the equator. So even if I have zonulisis, I'm supporting the zonules because I'm pushing towards the zonules, not away from the zonules. Everything is done under vision. You can see the fibers. I can crack it. This is what is called, people call it gummy nucleus. It is not gummy. It's only the fibers need to be split down to the edge. With this technique, everything is done under vision completely. Then you deal with the fragmented parts. You fragment it into smaller and smaller parts. This is just to show you how this vertical splitter, nucleus splitter, is very useful to manipulate the nucleus, and you can do this, the same technique, even in narrow.
I want to see, Dr. Yahya, exactly how you do the vertical, because we want to differentiate it. I mean, for those that are listening to us, what do you mean by vertical and horizontal? Just
immediately, I will show it to you.
Okay.
Here in the slow motion. See, now this is after the groove. In a regular case, you embed, this is your fork as if eating a steak, and you see the chopper is just splitting along the regular lines, normal lines of splitting of the nucleus, alongside of the tip that is embedded. Exactly like a fork in a steak. The fork is the phaco tip, and the knife is the chopper. You can see that here I'm doing everything under vision. And in this way, you can use the least power possible.
What is, can you explain in another way, the direction of the chopper in according to the phaco tip?
Yes, the phaco tip will be at one point.
For example, let me explain, because I want to make clear for those that are listening to us. If you are now holding the nucleus and your direction at 6 o'clock, your chopper will move from where to where? Just
the chopper, as if it is moving from 6 to 7 o'clock. Here,
okay,
you will see it again. You see here, it's holding, and the chopper will move sideways to split.
Okay.
Can you show the first chop?
Dr. Mohammed, we can see the modification also. Just if you allow me to show you the modification, is only one modification step that I have for that.
This is vertical.
Okay, can you do one more video, because Dr. Prasad, he want to see the first step. I mean, first chop,
first crack, not without grooving. The vertical chop grooving.
No, I don't have here video for a quick chop.
So ideal vertical chop means like you hold the nucleus at the center, go deep into the nucleus, and then your chopper, the sharp chopper, has to force against the force of the phaco tip. You have to bring.
Okay, can you see? Anyone have this one? If you have this one, if you have Dr.
Muhammad.
Many times I have a lot of videos, but not now in this presentation.
Okay, can we have, if there is anyone having,
quick chop, just embedding the tip into the nucleus, grade 3, grade 4, and with vertical chopper, you split, you go directly as a quick chop.
How your vertical chopper goes? Which direction? How deep?
Do you have?
Actually, the vertical, the chopper doesn't go deep. You follow the. I'm sorry.
How you enter the vertical chopper? Where you enter the vertical chopper?
Where I enter?
How you enter into the nucleus, the vertical chopper?
Once, if you are talking about quick chop in a nucleus like what we see now in front of me, I will go with the tip into the nucleus to hold it, and alongside the tip, I'm going to split, and it will split in front of me. And I can follow the crack as much as I want.
I think we are having some concept about this one, because we need what is Prasad is asking with the same question I was asking. You are holding, Dr. Yahya, the nucleus by phaco tip in the center. Okay. Then For example, now you are coming from 9 o'clock or 12 o'clock of the patient, your direction to the 6 o'clock, right? So you are going to put where you are going to start the shopper. This is the question. Where you are going to put it? In the periphery, in the center?
Not in the periphery, in the يعني you have to, it was obvious even in that.
I know.
If you have the nucleus like this, I hold it. Yeah, now you are holding, and the chopper goes alongside the tip.
And then you are pulling away or straight along.
Away.
No,
Pulling away.
So this is the difference between the other one. It will be a horizontal.
Exactly.
If we do it,
it is as if I am using the normal splitting lines. I'm just opening the splitting lines of the nucleus.
Okay. You have a doctor.
Dr. Mohammed, in vertical chop, the concept is, the actual concept of the vertical chop is you have to put your phaco probe deep into the center of the nucleus. Your chopper also enters along with the phaco tip. And then both the tips have to go on the opposite direction vertically, not horizontally. That is
anyone want to show this?
Yeah,
this is what I want.
That's the video in front of you, Muhammad.
Okay. Go ahead.
The video is ready.
Okay, go ahead, Doctor.
Okay, so here I agree with Dr. Prasad and Dr. Yahya. He showed us a very beautiful video. But
can we go direct to Sam? Direct.
Yeah, but I need just to show the idea.
Show us
the issues is that between vertical and horizontal. Okay. So here, my step before Dr. Yahya's step is that I'm splitting before starting the step of chopping. So that to reduce the power that
Can we see it in a video? Because explaining in the video is more
very clear, Muhammad. So it's clear now. I'm creating the hole. That hole should be deep and deep enough in a way that I can split both sides. So I will not continue to chop while I'm here. So I hear splitting in a way that I can do the hydrodissection, because as Dr. Yahya said that he didn't do the hydrodissection. So I split, I will stop it again.
No, 1 minute, Safwan. The aim is, until now, it's not, I mean, you are, I
didn't start the chop, Muhammad.
Okay.
Here, I just split it in a way that I have the way to do the hydrodissection and reduce the power.
Okay, let's go to the shop, because our aim now to see the shop.
Continue. Hydrodissection done, rotation done. So I'm ready now for the chop. Splitting it in a 2/2 equally, and
Safwan,
now, Muhammad, just be patient with me, please, if you don't mind. Now, see, I will stop it again as Dr. See. Now, here, it's a mix. That's what I need to show. It's very difficult to say that now I'm on horizontal or vertical, because one of this is the kind, as a concept, is a horizontal. Now, if we will continue here, firm, then the same. This is a vertical. So I'm using both in one. Chopping, holding the nucleus. Sometimes I'm the tip and the nucleus, I need to do a horizontal in it. So if I'm separating both sides, it's a horizontal. But sometimes I need to do a vertical, because now, again, I try to hold it again. It came to me. So I don't need to
Safwan, if you allow me, please. Until now, we need to clarify the directions of the shop. I mean the shoppers income with phaco tip it will be fixing. Now we want to know how it will move. This is the aim.
The concept of the vertical, as Dr. Prasad said. Now I will stop the video. The concept is that the chop and the chopper should be in the center and toward each on counteracting to each other. This is the vertical.
Yes.
Now, if the
this is the vertical or horizontal?
Yes, this is a vertical. Now, if the chop and the chopper separating the nucleus away from each other, creating an angle of 45 here, this is a horizontal.
Yeah.
But it's very difficult, Dr. Yahya. This is the concept that
I think Dr. Yahya is what we learn from Dr. Yahya is something different. Okay, Dr. Yahya, comment.
Yes, horizontal means you are commenting when you talk about, because sometimes it's confusing. When you comment about horizontal or vertical, it refers to how the chopper will move.
Yes.
So, and how the crack will be created. So in horizontal, like Dr. Prasad, this is horizontal chopping. The chopper moves horizontally.
Horizontal to the phaco tip.
Horizontal, parallel actually.
Parallel, if we move, okay.
But
I think it is the best way.
Vertical chopping, you are moving away from the, like it is vertical, like the crack is happening this way. In the horizontal, it is happening from periphery to the center. So
I think different what Dr. Safwan said. I mean, it's the opposite what Dr. Safwan said.
Yes, that's why I don't agree.
Yeah, I don't agree. Anyway,
okay, Hassan.
Let us return back to Prasad as a concept.
Safwan, please, 1 minute. Let me ask Dr. Hassan if he's a comment. Yes, Dr. Hassan. You are mute. You are mute, Hassan, please.
Yeah, I have two very clear videos about the horizontal.
No, I want your
technique
opinion about this one. Let us
and about the vertical. It depends on the technique that showed by Dr. Safwan and Dr. I don't think this is a clear vertical chop. It is pit and chop. The one showed by Dr. Safwan. You can make a central pit first. You can decompress the nucleus. Then you can do chopping. This is not a clear vertical
Dr. Hassan, we want to agree about the concept itself, if you don't mind.
Yeah,
this is because
horizontal chop, you have to hold and go by the chopper just underneath the cortex and epinucleus to the equator and chopping.
Chopping toward where? This is the direction. Where is the direction?
The direction, the direct of that chopper.
Parallel to the chop. That means is the
no, towards together, then opposite side.
This is what?
This is vertical and horizontal.
No, this horizontal, but from the equator, not from the central. When you are going to make vertical,
I think we are mixing now the information. We are making people they are confused. Can we ask Dr. Prasad? Yes, please go ahead.
These three techniques are absolutely different. In horizontal chop, what you do is you hold the nucleus at the center. Your phaco probe has to go into the center of the nucleus posteriorly, deep enough, and then your chopper is going underneath the capsular axis margin, not around the equator, but it's being placed at the equator, and then you are entering into the nucleus and then cutting the nucleus from the periphery towards the center of the nucleus.
This is what we call
horizontal chop.
Horizontal. That means if we are moving parallel to the
just wait. Dr. Mohammed, just wait.
Okay.
You cut the nucleus, come to the center at the probe at the center, and then you split it on opposite direction. That is horizontal chop.
Yeah, that is the horizontal.
Okay, let's continue. Okay.
On vertical chop. In vertical chop, you hold the nucleus at the center, go deep enough. Then your chopper is also entering into the nucleus adjacent to the phaco probe.
Yes, exactly.
Now
that's the vertical.
1 minute, Safwan, let's listen to me. Sorry, Safwan, sorry.
Now the movement of both the devices has to be on the opposite direction, vertically. Your phaco probe has to lift the nucleus, the part which is there, and your chopper has to press down. That is how you crack the nucleus. It's a vertical cracking. That is why it is called as a vertical chop. Where vertically you are cracking, not horizontally. Vertically you are cracking. That is a vertical chop. In my technique, in terminal chop technique, you hold the nucleus just within the equator. Your phaco probe is not in the center. It has to go towards the equator, hold within the equator. You draw the nucleus and then you hook the nucleus all around. Through and through, you have to hook it and then crack it at the equator itself, not at the center. So these are
okay. Do we agree on these points? Okay, from each one, Dr. Yahya, Safwan, Usama.
Yeah, agree.
Okay, Safwan. When راح Safwan? Yahya, Usama.
Yeah, I agree with the definition.
I agree, yes.
Okay, so I think now we make it clear. Definition for the different types of cracking of the vertical, horizontal, and cracks. What we call it, Dr. Prasad, that your technique?
Terminal chop.
Sorry?
Terminal chop.
Terminal chop. Okay. Safwan, you agreed now about the three definitions?
Because Yahya said that it's an opposite to what he said, so that's why I'm away from the issues that I say. It is exactly what Prasad said. Vertical.
Okay, no problem. No, you agree on the three now.
Exactly. Muhammad,
okay.
If you allow me, please. If you allow
Yeah, Safwan, Habibi, Allah yarda alayk. We are 45 more than 2.5 hours.
The chop should be reached to the phaco tip. That's to chopping, and that's the vertical. If the chop not reaching the vertical, if the chop not reaching the phaco tip and splitting away, this is the horizontal. So
okay, Safwan already he explained it. If you don't mind, he give the conclusion. So we want to say agree or not, because you are okay. Anyway, thank you very much. So there is anything else before we move, because already you are 2.5 hours. I know it's very interesting, but the people, I think it will be difficult. Usama, he's sleeping. Safwan is becoming, he's angry, hungry.
Yeah, go to the next one, please.
Can I show you? This is
okay. I can can I announce this one? Only one thing. For the management event, can you put please the certificate link on the chat? Can you download so that the participant can have the certificate of attendance, please? Okay. So within only 2 minutes, we need to finalize this one. I think we don't have a time to talk about the posterior capsule ruptures and to manage how to manage. Maybe we can do in another time.
So only in 1 minute, this is the horizontal chop that I prefer to do it. You see, go by the chopper to the equator. You can see the direction of the tip and the direction of the chopper.
Okay.
This is the first half. The second half. You can hold and go to the equator just underneath the cortex.
This is what we call horizontal, right?
Yes, exactly.
Okay.
So I will go now to the vertical. This is also a nice vertical video, clear also. You can see after shaving, impale the tip of the phaco at the center of the nucleus. You can see the pointed chopper in the, you can separate. You can rotate, then do separation for each half to be like.
Okay. So I think the difference is that
this is
I think it's very clear now what is the difference. Okay.
Yeah, that's it.
Okay. Thank you very much. Is there any comment from anyone? Just Dr. Yahya, Usama, Safwan, Prasad, before we conclude these sessions.
It was a very nice discussion. Thank you all for this.
It's informative. We are shouting, just we are all friends,
Of course.
Dr. Yahya, I think Dr. Yahya left already, or he is with us. Usama, Safwan.
Yeah, thank you very much. That's very, very good discussion. And as I mentioned, it's always this vertical horizontal, always confusing. But the majority of us, we mixed really both.
So at the end, we agreed. At the end, we agreed. No problem.
Yeah.
Okay, Safwan?
Yes, I agree.
Is any comment before we move? We conclude?
No, thank you.
Okay, Dr. Prasad?
Thank you, Dr. Mohammed, for giving me an opportunity to be here with you all, senior surgeons and expert surgeons. And definitely, I've learned so many things here. And it's my pleasure to be here with all of you, and really happy.
Okay, first of all, I would like to thank you all. I would like to thank you, Dr. Prasad, for being with us, and we are waiting also to see you in the conference. So we will talk about EDOF. Please don't, I sent just to remind you, because I didn't get a confirmation, but now we agreed. Thank you, my dear Safwan. All the time I'm shouting and fighting with Safwan, but we are a friend, nobody can think something different. Usama, he likes to love on us, but Usama, we are a friend, whatever you want.
Me and Safwan for dinner tomorrow.
You are going to invite
us?
You
invite us, so you need to invite us Safwan tomorrow.
Yeah.
Maybe Dr. Yahya will invite all to United States.
I'm waiting for you.
Thank you, Dr. Yahya. Thank you, Dr. Hassan. Very nice, excellent. Actually, this is one of the most, I like sessions. We show every step every I mean particular tips and tricks available in any step of the phaco emulsification, phaco surgery. I know there is one thing that we miss, maybe the posterior capsule, but maybe we can have another time. We already now around 2.5 hours, but it was great. More of the people that are until now stay with us. Thanks for all our attendees and participants. And we would like to thank you all. Thanks for management event. Thanks for Bausch & Lomb for supporting this event. And good night, and see you inshallah in the next week, inshallah. Thank you very much. Bye-bye.
Thank you.
Good night.
Thank you. Thank you very much. Good night. Bye-bye.
Management, do you have the what is the, you didn't post the link for certificate? Okay, and when it was just now, I tell before maybe 10 minutes, please, before the end of the session, 10 minutes, post the link. So everyone, the link is there. If the participant is there, please